Good evening, all. So today we are here with another topic in aphasia rehabilitation from SIG ISHA Clinical Aphasiology. I wish you all good evening and welcome to the Knowledge Evening series. We have brilliant clinician who is going to be talking on a very important topic in aphasia rehabilitation from her 25 years of journey, and to the topic lessons learned from my Aphasic clients, a journey of reciprocity. To moderate this session, we have very young aphasiologist, our own SIG advisory board, Dr. Gopi Krishnan. So welcome, Dr. Gopi Krishnan. Again, I don't require to introduce Dr. Gopi. As you all know, all the ISHA members are well familiar with this academician and the aphasiologist. He has a very great 17 years of experience to him. He has been in the field of aphasiology and he's been guiding many researchers in aphasia with his innovative research methods in assessment and intervention. He's well popular in Indian aphasiology as well as in International Academy of Aphasia. Welcome, Dr. Gopi. You can take it forward. Thank you.
Thanks, Sonal. Am I audible?
Yes, sir.
Okay, so can we just show the slide on Annamma? Anyways, even without slide, perhaps you can show it for the audience. But I know Annamma as a senior colleague, in the sense I was never, I never had an opportunity to work with her. But when I developed the interest in that, I respected seniors was Annamma's name. So including from my guide, Dr. Pratibha Karant, who actually was my mentor for my PhD program. Okay, all that what you want to read about Annamma is over there, but I would consider in the domain of speech language pathology in India, and especially in the subdomain of aphasiology, she is a peer, I would say. So more than this, I don't think I need to explain further. Very many of us do not require a special introduction to Madam Annamma. And those who want it, that's right in front of you in the form of a slide. Okay, so please have a look at it, and I wholeheartedly welcome Madam Annamma to this talk, and please share your experience of over 25 years of time working with the clients with aphasia, the give and take in aphasia. Welcome you once again, Madam Annamma, and over to you.
Thank you, Gopi. Thank you for that the introduction that you gave me. I'm indeed honored today to have actually been invited to give a talk in by ISHA for this thing. Am I audible?
Yes, ma'am. Your screen is also
okay. So I'm going ahead. Thank you so much. Okay. So when Sonal actually, she's been asking me from last October, Madam, can you give us a talk? So actually, due to certain circumstances, I was not able to, agree to her request last year. But finally, when I got down to it, something that crossed my mind, especially now since, like Sonal mentioned, I've completed 25 years of my professional journey. Something that struck me was, why can't I talk about what I've learned from my patients? And the journey has been one and such that it was definitely something of a give and take. There are many things that I learned from my aphasic clients. And since we have a student audience here, I'd like to trace my journey right from when I was a student to where I am now. So before I begin that, I bow my head in reverence both to the Almighty and to my teacher, Dr. Pratibha Karant. I was very, very fortunate to actually have a teacher like her. And I think my batch was fortunate enough to have learned from her right from first BSc. And we were the only batch she taught for 5 years. So there's a lot that I gained from her. And I think my first baby steps into aphasia was initiated only because of Dr. Karant. I'm moving to my first slide. I'd first talk about, just a minute, I have to go back.
Click on the slide. Yeah, yes.
Yeah, now it's come, isn't it? Yeah. So I'll first talk about my student days. So I knew nothing about aphasia at that time. And it was during my, of course, we did learn in our undergraduate days, we started learning about aphasia. But I actually got to see a patient when probably I was in my first year of MSc. And I was very excited. I was excited because I was handling the patient for the first time. And secondly, because for me, it was a chance to actually impress my teacher. And the student, and as a student, I got a very difficult client, as I would say at that time, because it was not a global aphasic or not a broker or anybody that I had to act on using my brain. Anomia, so he had also mildly reduced MLU and difficulty in writing. So I had to make a lesson plan based on what the findings were on the web, and I managed to write a very good lesson plan. And I was I was very, very happy when madam actually gave me a good on that lesson plan. So that motivated me. And the patient did very well with 3 weeks of therapy. He did very, very well, and the patient got discharged. So that was my first experience with aphasia. After that, it was during second MSc. For my dissertation, I actually chose the topic of developing the Malayalam English bilingual aphasia test. Believe me, I never knew what I was getting into. I never knew anything about bilingualism or multilingualism, and that was the earliest or the first reading that I had on this. And of course, I developed the test, and I, actually learned quite a bit just because I was doing a review of literature. And probably the culmination of that effort and the happiness I actually received for it was when I was able to share a platform with Professor Parady when he came to the Cochin conference of ISHA. That was my student days. Now, I started off my career, and in the beginning, I was at a hospital. I started in a tertiary referral center. So you should remember, right after MSc, I was armed with theoretical knowledge. I had the experience of seeing aphasics during my student days was very little. I'd seen only 1 or 2 cases. So I had the theoretical knowledge, and now is the time that I needed to apply myself, work practically. Now, the place that I work, the Sri Tirunal Institute of Medical Sciences and Technology, is a center for neurological and cardiological diseases. So I got referrals from neuromedicine, from neurosurgery, and from cardiac surgery because there were patients with post-operative complications. Now that is where I polished my bedside evaluation. That's where, I actually improved upon how to do bedside evaluations. And of course, there were referrals from the ICU. Now, whatever experience was gained from these evaluations and referrals, that led me to write chapters for the Aphasia monograph, which was published by ISHA in 2006. And I had Dr. S.P. Goswami as my co-editor, and we had also written some chapters for it. I think many of the students, have read the Aphasia monograph. Of course, it's high time we make a revision for it. But then that was one of our early work. Okay. As I move on today, during the course of my career, I have now this list that I'm doing today is not exhaustive. It is just that I am talking to you about certain scenarios or challenges that I faced during my career and what were the lessons that I learned from it. So I'm again saying the list is not exhaustive. And if any of you have heard me before, some of it may be a little repetitive, so please bear with me. I had made some of the repetitions just so that the students in this August audience would be able to understand me better. So again, I would like to say I'm not going to go deep into case histories or MRIs or even the other clinical evaluations. I will briefly touch upon based on the situation. So the first case I would like to talk about was a 55-year-old male with Broca's aphasia along with apraxia. I started him on therapy and he developed a 75-word single word vocabulary. And he developed excellent gestural communication with his family members. Now, this particular patient used to commute from Kollam to Trivandrum on a daily basis. Kollam was his hometown and Trivandrum was his workplace. So he would commute daily. Now, between the railway station and his workplace, there were 5 temples, which he was he was a very highly religious man. And daily, it was his routine to visit these temples. And then when he would go home in the evening, he would narrate using his gestural communication to his wife, which temple he visited, was the pujari there, did he meet any friends there? And it was a perfect understanding between them. Another good thing was that he received supportive help from his employer, who facilitated a job change. He was working in a bank and he worked as a collection agent. So the bank was good enough to shift him to the teller machine where he only had to count money, and which he was able to do perfectly. Now, from this client, what did I learn? I learned that not all aphasics will develop verbal communication, and we need to explore other channels of communication. Okay. Secondly, aphasics can continue to work provided the atmosphere that they work in is conducive. Now I'll move on to the second case. Now, this was also one of the early cases in my career. He was a 72-year-old male aphasic. He was a retired orthopedic surgeon. Now, he had a right hemiplegia, and this was one of my first clients that I trained to use the left hand for writing. So I'll just illustrate. This was how his writing was when he, in the beginning, when we had introduced him. I asked him to try with his left hand, because you all know that surgeons use their left hand while making the surgical knots, right? So I just gave him the pen and said, try with that. And this is how his writing, left-handed writing was after therapy. It's even better than my right-handed writing. Okay. So the lessons I learned from this particular client was that it's important to encourage the use of the dominant hand for writing in case the dominant hand is affected. Now, one question the caregiver will ask you is, will he not be able to use the right hand at all? So then you need to answer saying that once power improves in the dominant hand and he's able to hold the pen, we will get him back to using that hand. And one thing we have to remember is starting to work early on writing improves the self-confidence of the client. And we have to be patient enough. And this was one client who actually taught me to be patient enough to allow the client to speak for himself. Now, unconsciously, speech pathologists tend to fill in gaps, fill in pauses. We try to speak for them sometimes. So it's important that we do not interrupt while he's trying to speak. Because I remember in the early days when I used to do that, he used to tell, Nille, that is in Malayalam, and you say, please wait. He said, Nille, that means he wants to complete the sentence. So he wouldn't like me to fill in for him. Moving on, the third scenario. Now, this was a 76-year-old client with aphasia. I got the referral from ICU. When I went to the ICU to actually do the bedside evaluation, he just would turn his back. He wouldn't want to face me. So this client was not cooperative for assessment or early stimulation. So I gave up after 3 attempts, but I did record it in the case file. So this is important to all those who are working in hospitals. Make sure that when you see the patient, you record it in the case file. But what was the light at the end of the tunnel? The client, after he had a long stay in hospital, he was discharged. When he came back for follow-up, he came back for therapy, but this was after a period of 2 months. What was the lesson learned here? Do not force any client for therapy. They will come back to you and request your services once they are ready for it. But it is important to convey the importance and necessity of early stimulation and therapy to the caregivers. We had actually taught the caregiver what to start and how to do it at home. Moving on. This is a challenge that most of you face in clinical situations. Many of the aphasics who come for therapy, they will show considerable progress with therapy, And during the course of recovery, you see that they may develop the ability to use single word or short phrases. But they were unable to generate sentences or take part in a conversation. So the lessons that was learned here is that it is important in each therapy session to set aside time for conversation. You have to do conversational practice with them. Then only they generalize things to out of clinic situations. And you have to choose topics which are based on the individual interest. Now that elicits more responses. It is only when you spend some time with the caregiver and the patient that you will actually know what are the patient's interests. If you start on a topic which doesn't interest them, you will not get responses. Some of them are interested in politics, some of them in movies, some of them in cricket, some of them in current affairs, like that. Some of them, like I had patients who were, professional singers. So their interest would have been in singing. So if you talk something related to that topic, then you would get better responses. The next challenge is in terms of assessment. A problem that we faced was, I had a 38-year-old client. Her education was only up to standard 5. She had a history of loss of consciousness with deviation of the angle of the mouth and right hemiplegia. She had a history of bilateral cataract. She did not, on bedside evaluation, there was no vocalization. She could follow single stage commands, and there was difficulty in repetition and naming. So in this particular patient, we could not use visual stimuli to test her. So here, the lesson learned was, you may not be able to administer tests, in entirety to individuals with special challenges. So in this particular client, only the auditory subsets and naming using the tactile modality could be administered. So obviously, AQ was not out of 100. Similarly, therapy activities in this particular patient had to be reorganized using preserved modality. Moving on. Now, these are the other cases that we see during a neurological, when you work in a hospital-based practice. You generally see patients with right hemisphere disorders, pure alexia, mutism, those having aphasia following tumor resections or brain infections. Okay. Now, generally referrals in these particular situations are made to the speech pathologist for, one, it's to determine or to rule out the presence or absence of aphasia. And sometimes it is to provide a baseline. Especially neurosurgeons, before they want to resect the tumor, they will want to know what the baseline was. And then after that, they want to know, following resection, how the patient is doing. Now, it is imperative to test for reading writing disorders in all cases who present with a history of stroke, because if you don't do it, there's a high likelihood of missing out on these problems. Next is a 64-year-old male engineer. He had a road traffic accident with loss of consciousness. Okay. And he had a left temporoparietal contusion. He presented with slurring of speech and word finding difficulty. He also had behavioral changes. There was a lack of interest and a lack of motivation. And he did not have insight into the problem. And we did find that the expressive speech was fluent with mild anomia. The comprehension was good. He had reduced word fluency. Repetition was near normal. He had difficulties in attention. He had memory problems, calculation difficulty. He forgot passwords. He forgot his ATM pin. He was very active on social media prior to the road traffic accident. And after that, he just didn't want to use a smartphone. He was not interested in looking at WhatsApp or on Facebook. And his executive functioning deficits were also there. So in this particular case, we had to work both on the cognitive and linguistic components simultaneously. And the patient made considerable progress. And within a week, he was able to recollect the forgotten passwords. Okay. The next challenge that I'd like to talk about is the language barrier. Most individuals who are listening to me now are either polyglots or bilinguals. Okay. But there are instances wherein the clinicians face the language barrier. That means you encounter an individual either speaking a foreign language or a regional language. So what do? Most often we take the help of the caregiver, both to evaluate the patient and for therapy. But there is a tendency for the caregiver to unknowingly help or provide cues or prompts, and this will require keen observation by the clinician, and we need to intervene and stop them from helping the patient during the time of testing. Okay. But in these situations, one cannot refuse to see a client just because the clinician cannot communicate in the client's language, especially in situations where resources are limited. So it's important to counsel the caregiver in a language that you and the caregiver knows. Whenever possible, you need to refer them to a clinician who can speak their native language. So I will just like to talk here about two examples. One, I had a patient. Now Trivandrum is very close to Maldives, so we have a lot of individuals flying in from Maldives for treatment in Trivandrum. So I do get reference from those cases, but very often the patients that I used to get could speak English, or at least the interpreter would speak English, so it was easier for me, or they would speak Malayalam. Now, because they come for medical tourism, they usually bring a fellow caregiver or somebody who knows the local language with them. Okay, so we can communicate that way. But if the patient knows only one particular language, like in this situation, then I had to train the caregiver, and then I'd ask them to find a therapist in Mali, and they flew back in that particular case. The other case was a case who was working. It was a techie working at a technopark in Trivandrum, and he knew English, Hindi, and Oriya. Oriya was his native language. But following the stroke, he couldn't communicate at all in English or Hindi. So I had to teach his wife to help him, and we advised him. He went back to his home state for a few months, started therapy there, and he got back. Again, here his employer was actually very good, because they took care of him, gave him a salary. Even though he had developed a stroke, they were paying him a salary for the first few months, and he took therapy and came back. He was lost to follow-up, so I don't know what his present situation is. Okay, the next one is chronic aphasia. I'll get back to that after talking about this patient who was a 47-year-old housewife who developed a stroke and was initiated on speech therapy. The patient is still continuing with me, although irregularly, and it's 12 years since she's had a stroke. So I'll just show you. This was how her VAB was. You can see how she did on L1, it was 10.7, and L2 at 3.9. This was at baseline. And by 1 year, she had improved to 82 and 69.7. I'll just show you a sample of her writing too. So this was her Malayalam writing at baseline. And this is how it improved to at 1 year. This is her English writing. Yeah, I just want to say that she could not write at all in English at baseline. Okay, and this was how it was at 1 year. We worked both on reading and writing, both English and Malayalam was worked on, along with the other therapy activities. We did work on reading and writing, and they were good enough to send me pictures of how she writes now. Can you see this now? It's complete sentences, both in Malayalam and English. Now, this patient is still continuing with therapy now. Because of Corona, she's not able to come, but she comes once a week. And the reason why she's still coming once a week is she says that only if she's in touch with me, she will, continue to read and write. But over the years, what I have seen is that she's made tremendous progress. Her mean length of utterance have, increased. And she's able to talk in complete sentences now. She's able to communicate over the telephone without help, which is very good for me. But only if you do systematic assessments like this, will be able to understand how recovery is taking place in these patients. So it helps you to monitor progress and to plan management based on the individual's needs. Another point that I like to make is I have had individuals who have come to me 2 years post-stroke with no exposure to therapy at all, but all of them do show some amount of recovery. So don't refuse a client for therapy saying that they did not come within the recovery period. Okay, moving on to the last challenge, which we are increasingly seeing now, is we during clinical practice see high functioning individuals and they present with very subtle problems. Now these may not be picked up during our routine evaluation, but you should remember that even these things are considered disabling to that individual. So one needs to think out of the box. And the lessons learned while dealing with these patients is that the therapy needs to be tailor-made to suit the individual. And translation activities in these clients provide a very good setting for progress, because translation activities are very difficult. So doing this actually, helps them make very good progress. Okay. Now I move on to success stories. Success stories is my definition of success. For me, they are the Aphasics, one, who have returned to work. That means they had a stroke, they developed aphasia, they went through adequate rehabilitation and were able to return back, resume the jobs that they were doing previously. The second group are those who post-stroke and aphasia made good recovery and went back and were able to continue education, because now we are able to see younger patients also having stroke, right? Then the third for me are those who are able to meet their communication demands independently without the help of the communication partner. That means there is no help, no prompts, nothing. The individual is communicating independently post-stroke. And the last but not the least are those who are able to motivate other aphasics. An example is the patient that I spoke to, who I said had forgotten his passwords and all that. Even today, if he finds any patient with aphasia, he will make sure he will pass on my number to them. They may be within Kerala, they may be out of Kerala, but he will always make sure that, he will send my number to them. So they are the ones who are the greatest people who have advocacy for aphasia. Okay. Similarly, many of these people who have gone back to work and education and all that, they are also people who communicate to others that actually rehabilitation has helped them. Okay, what message do I have for clinicians? Especially budding professionals and students, I want you to remember that it is important to convey what you intend to do for the patient in a very confident manner. Body language, tone of voice, and manner in which you communicate really matters. The way you present it matters. Only then the patient will come back to you for therapy. It is not only important to gain the trust of the caregiver, but also that of the patient. So what I do is, after the assessment is over and I speak to the caregiver, then I speak to the patient also, and I tell them that, you have a problem with your language, but don't worry about it. We are going to start therapy. Are you ready? Next week, I'm going to give you an appointment. Are you ready to come? Is the thing that we communicate. So even though the patient cannot answer you verbally, he may nod his head or smile, or show you a gesture saying that he's ready. Okay, so we need to talk to both of them. You need to be a patient listener and spend adequate time with the patient and caregiver. Very often, the gravity of the problem is often understood by the caregiver only after they spend time with you. Now, why I say this point specifically is that most of the patients referred to you are either by the neurologist or the treating physicians. So, it's a busy clinical practice. They don't get time to spend that much time with the patient. So it's only when they come to the speech pathologist and when you talk to them in detail that they realize that this is what I'm going to face and these are the problems that I'm having and these are the possible solutions for the problem. So that is possible, that communication with them is possible. So they are very grateful to you that actually you have communicated to them, taking time and, you know, spending so much time and telling them what the issue is. Then we have to be very careful with our facial expressions because they are able to read them very quickly. I have many patients who, you know, they'll sit across the table and in the morning they look at you and they'll say, "Madam, how are you today?" Or they will ask, "Is something wrong?" They read it very quickly. Okay. Then in my experience, clients having Wernicke's aphasia are the most difficult to treat, and some of them may discontinue therapy. I've had success stories too, because I have people who have evolved to transcortical sensory aphasia. I even had the 29-year-old who did so well, and he went and opened his own shop, and then he sent me a greeting card saying, invitation card rather, inviting me to his shop. So those are moments of happiness, but usually they are very difficult to treat. Some of them discontinue therapy. We have to remember that we are being increasingly challenged nowadays to innovate and adopt newer techniques to meet the communication needs of our clients. And we need to blend both the old and the new, because today clients and caregivers today are well informed and their expectations are sometimes far away from reality. Getting an aphasic to smile truly brings immense satisfaction to the clinician. Their gratitude may be expressed through a simple smile, tears, a heartfelt thank you, a handshake, and warm goodbyes. They have all meant so much to me and motivated me to think differently and find solutions to their problems. For me, my hope for the future is to see that all aphasics have access to quality therapy services, employment opportunities, and barrier-free environments both in the rural and urban sector. So let us all continue to work together to improve their quality of life. I end with this quote.
Am I audible? And am I visible? I think that's fine. Sonal, am I audible?
Yes, sir. Go ahead.
Yeah, thank you, Madam Annamma. It's been, I've listened to you many times before, but every time, you know, there's something new that you convey, even for the repeated listeners of you. And thank you for that wonderful, like, you know, clinically driven kind of, like, you know, experience-based, like, you know, insightful talk. Miss, I was actually, like, you know, going through my own experience. Miss, I know I have a question related to this. Even before the kind of audience asks you, I have one or two questions to you. In the sense, not a question, opinion. Because I also work in a tertiary care hospital. You have worked already, and now you have changed from there. Now, in my understanding, you are a freelancer. So my first question for that towards this particular aspect is that what are the main challenges that you experienced when you worked in a tertiary care hospital and now as a freelance speech language pathologist? And thank you for that good talk.
Welcome, Gopee. Welcome. You're talking about, you want to know the differences between the tertiary and now, like now I have a private practice. Okay.
Yeah.
So you want to know the differences, the challenges.
Yeah.
Yeah. Okay. Probably I'll put it another way, because both have its pluses and minuses. Okay. If you in the hospital sector, I had referrals across, you know, across departments. That is from cardiology, from neurology, and I'm not doing now in this kind of a practice. I don't have a pre-surgical, post-surgical kind of cases. I'm not getting now. In fact, I get more of the ones who have recovered a bit, or like, you know, they have post-traumatic. Neurosurgeons who work in private hospitals send me the post-traumatic one. Now, like I said, a barrier-free environment, which is not possible now in my practice, so I can't take the acute aphasics now. So that was an advantage that was there for me in the hospital. I was seeing the acute. I'm not seeing the you know, immediate post-stroke now.
Okay. Yeah. Okay. No, I understand that because you mentioned that because you presented a series of challenges based on your experience. It's actually a challenge. Every case is a challenge. It's a multi-dimensional challenge, even a single case. From our perspectives, because especially when you work in an academic environment with so many other wanted and necessary and the so-called unnecessary targets and all that, now dealing with the clients is actually a challenge, and also working up to the expectations of our co-professionals is also a equally demanding challenge. That means because we work in an environment where other professionals also actually work together, so they look forward to us for the kind of means we have to live up to their expectations, which we are experiencing on a day-to-day basis. Okay, now I have a few more questions, but now I'll stop here and let's invite some questions from the audience. Sonal, could you please help?
Yes, sir. So we have a question from Subhashri Sahu. What I understand from that is there are many signs and symptoms are seen in aphasia, madam, but any particular one sign or symptom you define for a particular aphasia type? Can you highlight on that, ma'am?
See, what is, like you said, see, all of them will have some kind of word finding difficulty. Irrespective of the type, it is the paraphasia type which differs across. Okay, so if you find word finding difficulty, that is the one that is most, what you say, call that a most common sign.
Okay, I think, yeah, now I could see. Okay, so now the Aruna Prabhu has asked, in private practice, what would be the average time lapse between the onset of aphasia and seeking therapy? In private practice, that's important.
Oh, okay. It's quite dependent on who you're getting referrals from. Now, see, for me, thankfully, all my referrals are from neurologists. So they send the referrals to me quite early. Like as soon as the patient is discharged from the hospital, I get a referral. Usually it is like 1 month, 3 weeks to by 1 month, I'm getting my referrals in private practice. The Aphasic. That is following after the neurological stabilization and after the patient is discharged from the hospital is when I get the referral. Most often in Trivandrum now we have most of the major hospitals have in-house speech pathologists, so they would have already started with speech stimulation and early stimulation and therapy for them. And then when the patient is discharged, the referral comes to me and then I start them on therapy. But I get them very early. It is very rarely that I'm getting the chronic. That means 1.5 or 2 years after the onset of aphasia.
Okay. Yeah, the next one is that any of your patient is able to write a book as a success story in local language. This would be something very useful. Asked by Rajat Shinoy. He's a local guy here in Manipur. Yeah, that's why he's asking about local languages.
Rajat, actually, the one or two of my patients who have had long term, they passed away now. Okay. But other than that, I have 1 or 2 people who may be willing to actually share their success stories. And I've actually personally not asked them, maybe I should.
Okay, so next is from Bibhu Prasad Hota. Shall we start therapy before cranioplasty or after cranioplasty? Neurosurgery related.
After.
After.
Because
obviously after.
Yeah.
Yeah, please go ahead.
I would like to comment on that. See, Mr. Bihu, there are many patients who would have cranioplasty after 3 months, where the bone will be replaced. So sometimes post craniotomy, you need to work on person's communication, safe swallowing, and cognition. So it's craniotomy and then the cranioplasty. However, post cranioplasty, you get a better results because at that era you have a better CSF and the decompression is done, and the language networks are well taken up. However, you need to understand the neurological stability of patient. As soon as the person is stable, able to come to you, or you are able to take teletherapy, you should start working on that. Isn't that, ma'am?
Yes, but because he asked that question, plasty, that is why we answered it that way.
Yes, ma'am.
Okay. That's good. That's fine. Okay. So now I think yes, there are some questions related to technical issues and all that. That's fine. Some voice is not audible. All that is fine. Okay. Okay. During previous seminar, Dr. Apurva had talked about formal standardized testing versus informal or ad hoc testing. Could you share your views on that? That's a good one, especially from a clinician like you. Yeah.
See, whenever available, we would still want to do a formal test. Okay, a standardized formal test is what is the ideal situation for us. But in India, the present situation is not ideal. You have to resort, like for example, you have the previous case that I said, when difficulties are very specific and it is not picked up on a test, you may need to design something out of hand to pick it up. But that doesn't hold good when you write it up. It's good for your clinical practice. So when you have to write up things, always it is better to have a standardized test. But for your clinical practice, when you have to get results then and there to help you with therapy, sometimes you have to resort to ad hoc tests. So that is exactly why I included that on the slide on high functioning individuals, because some of their problems are very, very specific, very specific. So when that specificity is noted in clinical practice, you make sure that you do things based on the client's need. Then you have to resort to the ad hoc test. And I think at this stage, like we had spoken during the last seminar also, I think it has been one of our goals for the expert committee in aphasia to make a compendium of tests that are already available in India, so that people are aware that these are available and that you don't have to invent the wheel again. You don't need to keep redoing the same tests again and again. If it's available, please go ahead and use them. But if it's not available, at sometimes you, especially in clinical practice, you may have to use the ad hoc test.
Okay, I think there are some more questions pouring in over here. So one next question is, so the previous question was asked by Aruna Prabhu. I think I know her. Can you suggest some basic activities which we can start for different types of aphasia? I think, okay, over to you. If you have a short question, yes, you can get back to Jisna Lakshman.
You want me to answer that, Gopi?
If you have a short answer for that question, you are welcome. Yes, we can share the details of the participant has asked.
Yeah, no, because she has asked for all aphasias, no?
Yeah. And
That's why I said I cannot finish it in a, yeah.
Okay, yes. Just now, Lakshman, please listen. You can get back to Madam Annamma, okay, later, and she's available. In the sense, I think she would not mind it sharing her email ID with you. Obviously, yes.
It was there on the first slide. It was there on the first slide, or you can even WhatsApp me or call me. I'm ready to talk to you.
And Shubhashree Sahu has asked whether can you share these PPTs to my email ID, not mine, her email ID. Email ID is given. Miss Sonal, please make a note of that. I think if Madam doesn't mind sharing it, yes, please. I think we have plans of hosting this up also, right? The entire video content with the consent from the
Sir. If a speaker is giving consent, we would try to upload the webinar online, and we would try to even send you handouts So it will take some time. Thank you, Sahu.
Okay, now comes a clinically driven question from Dr. Kiran S. Any tips to manage limb apraxia as well as motoric perseveration in a 42-year-old client with Broca's aphasia, madam?
Personally, I have not.
Tips on managing limb apraxia as well as motoric perseveration.
In my clinical practice, I have not seen a patient with motoric perseveration. So if Gopee, if you have seen, you can answer that.
It's hard because all these automatic involuntary behaviors, okay, whether it is behavior or motoric, is very difficult, such as what we otherwise find it in, like, this hyperkinetic type of dysarthria, all this kind of involuntary movements. It's my experience that, like, it's quite difficult to behaviorally handle that. Kiran, perhaps you can get back to us maybe after this, in the sense you can discuss, perhaps we can share whatever little knowledge that we have on it with you. Okay.
There's a possibility
so next,
that probably tapping can work. Tapping can work with them.
Tapping can
Sonal,
work, and mirror therapy can work. Now see, the hand movements are very important for your writing, for your gesture. So I always tell all the clinicians or the students whom I taught and teach that it's important that you work on a person as a holistically. So all the communication modalities are important, and hand movements are important when you have extra stereotype behavior or extrapyramidal syndromes with aphasia, and that might be even hampering the communication. So with your OT, it will be helpful if you combine a good rehab strategies which can lessen the movements which are unwanted, undesired, and the tapping and engaging the hand, which is extra moving in a different activity, could be helpful. So limb apraxia, dysdiadochokinesia, oral movement, and oral verbal apraxia, if at all the praxis is improving, even the verbal and non-verbal aspects also could be improved.
At least we can hope so. Right, Sonal?
May I have
fine. Sonal,
comments from you, Dr. Goswami sir, Dr. Shivshankar sir, as we have a panelist join. So a comment or a remark would be
okay, I am
welcome.
Sorry, I am just looking at the questions. Okay, now.
Okay, sir, that would be really great. Yeah, you can go ahead.
Yes, I can now see Shivshankar sir. Sir, good evening. Welcome, sir. Not able to hear, sir.
Shivshankar sir, we can't hear you. Can you please unmute?
Yeah. And I think he's trying. Yes.
Yes, sir.
Yes, sir.
When Sonal asked me to be the panelist, I said I want to learn from Annamma. I don't want to be a panelist. It is such a nice learning. You have given almost 10 to 12 challenges, and I have made a note of all those challenges. Use of non-dominant hand, topics of individual interest, preserved modality, rule out presence or absence of aphasia, test for reading and writing, RTA patient to go with cognitive linguistic approach, case giver influence on testing, chronic aphasia, excellent improvement means brain accommodation and neuroplasticity, translational activities, very good approach, that's the use of cognitive resources, clinician communication skills, which is, you have really spanned across all the clinical challenges for the students to learn how to approach a patient. Most importantly, I would take it as the skills that they should learn to talk to the patient about what is happening to the patient. Why is patient is not speaking or not responding to your question? Generally, we don't touch upon that. We test and we say, come back for therapy on such a date. that is not going to help at all. So we need to explain what is the current status, why it is happening, how the brain behaves in the communication, and what are the resources the brain has to do it. And you have given a wonderful examples and a very excellent improvement that you have shown with the approaches that you have mentioned. One aspect that I would like to ask you, Annamma,
Yes, sir.
what are the initial steps of therapy that you would like to inform listeners with Wernicke's aphasia? You know, you have said Wernicke's aphasia is a tough population.
Yes, sir.
Okay, what are the initial steps for Wernicke's aphasia?
So what I've seen with the Wernicke's is that they do very well with the visual modality. So I always tell them that you give them the cues visually rather than auditorily. If I give something auditorily, it has to be short, it has to be a single word, and I make sure that the patient, attends to me. He has to look at my face when I'm saying it. When I do both this, then they start showing progress. But it takes time to break this barrier. Anything, I always say, presenting auditorily is very difficult for them. You try with the visual modality, and if it is auditory, short, single utterance.
Yeah, in the auditory modality, if it is a linguistic information and it's go heavy, they start circumlocution and that. But if it's a non-linguistic,
Yes,
like variation in the temporal patterns, rhythm patterns, pitch patterns, and if you start working on those, get the attention to what you are doing, and then probably go on to a word level, would help the patients to understand what they're supposed to do. And that's what I would rather approach the patient. Now, other important talk that you mentioned that you made, standardized test versus non-standardized test. Well, I think time and resources in private practice is very important. How much time that you give, particularly when you're attached to a hospital, how much time that you give for each patient, because you're slated for next 2-3 hours, 3-4 patients, and you got to finish it within that time span. And therefore, for a research purpose, it's a different ballgame altogether. But for a clinical purpose and the immediate therapy programs, I think is non-standardized. I would rather say, talk to the patient, talk to the family members, keep your ears open, keep your eyes open, you get the diagnosis. Your standardized test will probably validate your. Okay, so that's what I would say. Can you hear me? Is it echoing?
Yes, we are hearing. We are listening. Yeah.
Okay. All these things are very, very interesting to me. And as you were talking about each patient, I remember about so many patients in my clinical practice, how we approach those issues, like particularly when you say diagnostic formulation. When a patient comes to you and they refer to you, that at times he does not respond, she does not respond. After a few minutes, starts responding. Aphasia, non-aphasia. A lot of tests, and then we found it as a human. Let me not go through that. It's time now. Thank you very much, Annamma, for your nice, lecture, which I wanted to attend, and I'm so happy and blessed. And I think one day or the other, I should also attend Gopi's talk. I missed his talk, and I would like to learn more from you, younger generation. Thank you so much.
You're welcome, sir. I will talk to you, sir, for 1 hour. No problem. Leave the audience.
Okay.
Thank you very much, sir. Annamma, I have one interesting question in this chat box. That is from Vibhu Prasad. So, ma'am, are non-word repetition tasks effective for improving naming? Non-word repetition.
Hear you, Gopee.
Oh, sorry.
Yeah.
Am I audible?
Yeah.
Am I audible now?
Audible. Go ahead.
Okay. So the question from Vibhu Prasad is that whether the non-word repetition tasks are effective for improving naming.
No, I have not used that for naming. I have not personally used that for naming. I have used that to improve reading.
Okay. 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 Bibu, if you are listening to this, okay, non-word repetition can be used to enhance the phonology because it obviously it doesn't have the semantic content associated with it. So if you are dealing with a client who has more of a phonological deficit, such as like a lot of phonemic errors in their verbal output, or means in fact even like if they get what do you say, if they tend to get benefited with the phonemic cues, perhaps you could try that because non-words do tap the phonological aspects of language. Okay, not the semantics one. So obviously we could try, but obviously we can try this. That's a very valid and very good question. And this, okay. Okay, another one question, I think it is from his experience, I believe. What was the response from the caregiver when you suggested alternate mode of communication or gesture-based communication? Did they accept that? Asked by Rajat Shinoy. I know he suggested this to one of his clients.
Okay, see, Rajat, I was green behind the ears when I the first slide that I showed you. I was not the one who taught him the gestures. Developed the system by themselves. You know, I had just probably during my student days read what is AAC, but I had not, tried AAC on any patient. Before I could try, the patient and the caregiver had already developed it. That was a choice they made. I never had to even tell them anything about a gesture system. But today, if you ask me, if I'm given a same client, probably I will place the options before them and allow them to make a choice. That doesn't mean I will still not try verbal, modes of therapy for them.
Gopee?
But I need to explain options to them now.
Yes, sir. Yeah. Yes, sir.
Yeah. Further, when you want to suggest gestural communication, we need to make them understand why gestures are necessary. Demonstrate that with the client family members. Show them how the gestures are important for communication. And that is one of the mode of communication. And I would always tell them, as you enter the room, how did I ask you to come inside? That patient says, sir, you raised your hand and then asked us to get inside. Now, did I do it like this or did I do it like this? Did I say get inside, get inside, get inside? I did get inside, get inside. How? It is a rule-bound activity, and therefore it helps for a person to communicate well and probably enhances the verbal output also over a period of time. That's what I think we should go ahead. For the lighter side of the today's talk, Gopi Krishna, you are throwing a lot of light on this topic, but I think you should also have some light on your face.
These are about Maxima, and I am sitting opposite to my light, so I want to be. Am I visible, sir? Now,
little bit.
I will send a photo of you. Sorry. Well lit up. Actually, yeah. Actually, you in fact ignited on a very crucial topic, which I think I've shared with my friends and colleagues, because we as speech language pathologists are actually limiting ourselves to only speech and language. That's a very sad part of it. You see, do we explicitly study, other than that particular AAC, do we explicitly study and try to foster or facilitate the alternate modes of communication in our clients? We think that communication is only speech and language and hearing, and that's the sad part of it. Many of us are actually experiencing.
That's only 7%.
So
93% we have many things to do.
In fact, we do it on a regular basis in our life, but I think this is something like, which I wanted to say, that I think the domain, the discipline of speech and hearing should be, I think, at least within our circle, I would say that, like, it should be kind of rephrased. It should not be, we should not limit ourselves to speech and language or hearing alone. We are dealing with the communication skills, and everything that is useful for communication, we shall foster and facilitate, and we shall encourage. And because we speak a lot about it, because we can speak, but later, maybe after some, anyway, touch wood, let nothing happen to us. But look at those people who are on the bed and then struggling to communicate, and we enforce only speech and language. And that's something really I wouldn't personally, maybe as a professional, we may have to accept it, but as a person, I wouldn't completely agree. I think maybe the budding ones, or maybe we ourselves, the not so aged, but not so young also, can actually take it further forward.
One of my patients wanted to go to Sringeri, and he had to communicate it to his wife. There's no verbal output except for 5 to 6 words. And he said, he called her and said,
Okay.
Then she said, is it Sringeri? Then he said, yes. What a wonderful way of communication. And he was so happy, and he was taken to Sringeri and came back. Unfortunately, that person died because of COVID. That's a different issue. And I was working with that patient and improved to an extent that he was able to get at least 8 words in a matter of 4 months of training, and improved on gestural communication, and improved on his emotional things. And Annamma was telling something like, you have to topics of individual interest. He was a mechanical engineer and a thermodynamics engineer, IIT professor, and I had to read thermodynamics for him. And I studied thermodynamics for a few chapters, made MCQs on thermodynamics, and then gave it to him. And he was so happy on that day that somebody who do not know thermodynamics has put in so much of efforts to understand thermodynamics and bring it to me to train me. And he answered all questions there. Such a wonderful. So that is where I think clinicians should be open-minded. Clinicians should always, think of out of the box phenomena. Gopee?
Yeah. Thank you, sir. Thank you very much. Miss, I think Miss, a message is conveyed. I think with Annamma's talk, I think yes, we shall not limit ourselves to only the speech, language, and hearing. We deal with the communication skills of the people. So everything that facilitates or fosters communication is a matter of a subject for our discipline, including a smile. Okay. Anyways, okay, and just one question that I had a few questions, but I think this one, like, we can discuss. But I just wanted to ask. I know time is running short. We are already crossed the time. One simple question. Okay, while managing, this is my own question. Okay, I just want your opinion. That's all. While managing persons with aphasia, what do you think you had not learned while you were in the college? Not that you did not learn, I know that you wouldn't dare leave anything unlearned, but the system did not teach you, which you thought that was essential for you to perform as a successful clinician. You got the question, ma'am?
Yeah, I got the question. See, during my time, I'm talking about 91 to 96. We were not attached to a hospital. Okay, so there is absolutely no exposure to how to do a bedside evaluation, or how to do anything in the ICU, or in an acute care setup. What is the clinician supposed to do? There is no clue. I learned by myself. When I went to the hospital, I was observant. My eyes and ears were open, and I just, it was hands-on learning. The college had not prepared me for that, because at that time, that was how the situation was. Now it is not like that. All are having exposure to hospitals, no? And at least during internship, they are going to hospitals, or teaching institutions have attachments with hospitals. So now the situation has changed. But during our time, we all learned hands-on only. I hope I answered you, Gopi.
Now I have better visible. Thank you for that. Because I changed my position, so now light's also on my face. If not here, a little more. No, I was watching the TV. Anyways, thank you, ma'am. I think that clinical exposure is actually something quite important. I know the internship is actually a good, experience for many of the budding clinicians, because very many of the institutions do not have access to the hospital setup. So in that 1 year, they get that exposure elsewhere. That's a good thing, in fact. And even I have personally noticed in our own students like that, once they get into the internship, the entire stature of the students, they are no more than the UG students. Like, they act like an independent clinician, if not all, many of them, which you would not see them during their training years, the first, second, and third years, where they are bombarded with all those theory classes and things like that. I have noticed this. Internship is actually a good, venture in that way. So Sonal, I had a few more questions, but we have only 10 minutes late. Sonal?
So we can take a last question if you want. It is important.
Okay, so let me. Do you see some insightful question in the chat box?
I think important question, and the last question would be, Dr. Amit Anand asked, how do you deal with caregivers who say patients are doing very good in sessions, but transfer of the same therapy at home is not seen? So if you can please answer that and motivate clinicians, that would be helpful. And then Dr. Sunil Kumar can please give a concluding remarks and word of thanks.
Actually, see, that's another complaint that many caregivers tell me, that the patient, madam, he's so cooperative in the session. He does all the exercises here, but he doesn't do that at home. He's not cooperative with family members. So I think one point that I always get them to understand is that getting up one day in the morning and not being able to talk, right? Just put yourself in that person's shoes and see how it feels. So that ability of, to losing the ability to speak, the amount of frustration that the person has, he does not take it out on the speech pathologist or the doctor who's helping him. He will take it out on the person he loves the most. And who is that? It's either the spouse, the caregiver, or the children who's there around him. So the loved ones are the ones who face the brunt of what he's feeling. So I keep telling them that you need to take it patiently. Do not lose your cool with the patient. Give him time. He will start responding. You have to understand that there will be mood swings. So this is how we reassure the caregiver, to deal with it. Or sometimes, like it was asked in the question, sentences that may be used here may not be used at home. So it is the job of the clinician to motivate the client to say this at home. So sometimes I even tell them that, please do that. I will call your wife and ask her, did you do it? Did you say it? So when I say that one line, then he's a little more, cooperative at home. So that is how we manage issues like this.
Okay, yeah, I do see a few more questions which are perhaps good enough to be asked, but our time doesn't permit. Obviously, please, those of you think that your questions are not answered, please get back to Madam Annamma. Her email ID is given in the first slide itself. I'm sure that she will get back to you with a response. Okay, and I thank you, Madam Annamma, for your insightful talk and also spending time with our attendees of this evening webinar. Thank you very much.
Thank you, Gopi.
Thank you so much, sir, and thank you, ma'am. May I call Dr. Sunil Kumar Ravi to give vote of thanks, Joint Secretary, Indian Speech and Hearing Association, please.
Good evening, one and all. On behalf of
Sunil, we are not able to hear you. Can you please speak loudly?
good evening, one and all. On behalf of Indian Speech and Hearing Association, the Executive Council of ISHA, and from the SIG on Clinical Aphasiology Group, I extend my sincere thanks to Dr. Annamma George for accepting our invitation to share her experiences of what she has learned from her own patients. It is a wonderful evening, and she had given us so many examples. Basically, see, as a budding clinicians, most of us do have most of these questions as to where to start, how to go, and what to encourage, what to not to encourage, and things like that. But then this particular lecture has given us a detailed orientation to most of the budding SLPs about how to proceed, especially the possible challenges and how to handle and things like that. Thank you so much, ma'am, for your a wonderful lecture, and we are also looking forward to have you on board for a few more in future. And I also extend my thanks to Dr. Gopi Krishnan for being the moderator for this session and making the session so interactive and contributing from his side. And thank you, sir. And I also thank the pioneers like Dr. Shivashankar sir, Dr. Goswami sir, and other senior professionals for joining us and also sharing your experiences about the aphasia rehabilitation and also the challenges that are seen or faced during the therapy sessions, especially. Thank you, one and all. And also, I take this opportunity to thank all the attendees for joining us on this evening discussion program. I hope all of you have enjoyed, and we also look forward to have you on for our future programs that are going to be organized by the SIG Clinical Aphasiology Group. Thank you, one and all. Over to Sonal.
Thank you so much, Dr. Sunil. Thank you all. Stay safe and stay tuned. We have some more very wonderful and informative sessions planned. Thank you all.
Thank you, Sonal.
Thank you, ma'am.
Welcome.
Yeah, thank you all. Thank you, Sonal, and thank you, Madam Annamma. Take
Thank
care.
you, sir.
Okay. Yeah.
Bye.
Bye.
Thank
you,
Take care,
ma'am.
please.
Bye.
Bye.
Thank you, Amulya.